Good afternoon, everyone, and welcome back to the, I think, most difficult session in the day. That's the post-lunch session. I hope you all have a good lunch and ready for this heavy discussion because it's a core technical topic of surveillance and how to strengthen maybe surveillance systems overall and try to learn from various countries how they are doing surveillance strengthening system and what we have did till now because maybe arguably this is the most evolved theme in GLC for HSR. We have why I'm saying this. Maybe I will go through my presentation and try to run you all through the journey we had till now. So before that, maybe I will just like to welcome all our online panelists, Dr. Aruna Panda, Dr. Oscar Primidi, Dr. Cheng Ye Lee, and like to invite Dr. Vijay Eldandi and Dr. Sneha Nikam on stage, please. So I would like to introduce each of the panelists just before their presentation so that that memory will be with you, that who exactly they are and what they are doing and how they are trying to contribute in the space of surveillance. And before going to that, I would like to introduce myself. My name is Dr. Shrikant Kalaskar. I'm currently working as a technical head public health with Access Health International and coordinating the theme of surveillance with GLC for HSR. Would like to run you through quickly through the journey of surveillance, what we had till now in GLC for HSR. Can we have my slides, please? Yeah. So as I said, this is the most evolved theme of GLC for HSR. And why I'm saying this, because if you can see, there are so many discussions till now we have organized while conducting the conclave of GLC for HSR. As you all know, this is a third conclave. We had started this theme 3 years back where we thought that maybe we'd like to contribute in various domains of surveillance. By pulling in knowledge, we have established a special interest group with surveillance experts all over the globe. They have contributed and guided us throughout this journey of strengthening the surveillance systems. And in the journey, we have named it as a surveillance alert and response system because we believe that there is a must of alert and response also. Obviously, there needs to be an alert, but how we respond is something what we want to maybe focus more on. So as you can see on this slide, maybe a bit of a crowded slide, but yes, we have conducted a panel discussion in annual conclave of 2023. Then we had a workshop on building back better surveillance system with our partner TICS and NCBS. We had again a discussion in annual conclave 2024 in which was organized last year in Singapore. And we recently had a roundtable discussion in this particular campus, the other room, which had given us various insights on how to maybe develop or what is the need of blueprint for strengthening the surveillance alert and response system. So we have got various insights from that also. I'm not going to go into the details. Those all proceedings are available on our websites, and those who have joined us as a members, we keep on sharing whatever insights we are getting and whatever if anyone wants to join a particular theme as well. So simultaneously, our team, Mehnaz is here. So we have done a systematic review on surveillance systems assessment approaches also. It is still under review and hopefully we'll get it published soon, where we have found out various indicators which multiple countries are using for assessing their surveillance systems, basically. So we always believed that with Dr. Reddy's thought process that there has to be first assessment, and then only we can move on to maybe steps for strengthening it by finding out where are the gaps and then strengthening the system. So that particular paper is under review and we'll soon get that published as well. So as I discussed, like in the previous roundtable, we had various insights on how the blueprint for surveillance system, response system strengthening is needed. Um, there, when we have started the secondary review of various blueprints available over the globe, then we found few of these blueprints, policies, papers published by various countries. Like first one we found was very interesting from the which is called as Canada Blueprint, how they are focusing on infrastructure and collaboration for maybe strengthening the surveillance systems. Then we came across the National Action Plan for Health Security from Indonesia. And with this literature only, we found our panelist for this particular session, because we have Dr. Oscar Primidi representing Indonesia's National Action Plan for Health Security here. Then we came across Korean Disease Control Agency white paper as well. So they also talk about how they have developed the policy, or how they have developed the plan for strengthening the surveillance system in their country. And we had a white paper on Taiwan's epidemic prevention policy in post-COVID era, basically. So we have reached out to all these people. Few we got hold of, like from Indonesia and from Taiwan. Few we could not reach out to. So that this is the whole purpose of this particular collaborative, that bringing the knowledge together and the learnings together from various agencies working on these particular thematic areas. So we have Dr. Cheng Yi joining from Taiwan as well, who will be talking about his view on this policy, as well as role of CDC in Taiwan for strengthening the surveillance systems. So what we have discussed in the previous roundtable was how to maybe develop a blueprint for strengthening the India surveillance systems. And simultaneously, we went through the various initiatives which have taken care by NCDC, IDSP, which are the backbone of surveillance systems in India. And we came across various initiatives, newer initiatives, which NCDC is also taking. But I guess I will not go all through these initiatives, and I will skip this. And then we have the some of the initiatives which could catch hold of, like Vadvani AI, which is supporting some of the initiatives of NCDC for their surveillance system with the help of newer technologies and AI. And obviously, we have Dr. Aruna Panda, who is again Director of Alliance for Pathogen Surveillance Innovations in India. So she will be sharing her views on this particular aspect. So this is how this panel has been constituted, to give us a glimpse of what has been going on all over the world in various countries, which has a stronger surveillance systems, or at least a policy or action plan, and what are the newer initiatives which India also has. And obviously, we have a veteran with us, Dr. Vijay Eldandi, who is our veteran and regular member of the surveillance thematic group, and he himself being the infectious disease specialist. So he is also going to share his views on how to strengthen the surveillance systems. So maybe I would like to take this opportunity to invite those who are working in the field of surveillance and wants to contribute. We are open for collaboration, and if you have any case studies, any presentations, or work around the surveillance systems, you can maybe mail us or join our collaborative with the membership, which we have already created a special interest group which particularly focuses on the public health surveillance and strengthening the surveillance alert response systems. So maybe I will like to stop here with this. Those who are interested, maybe scan the QR code and join for the membership as well. Uh, I would like to now hand it over to Dr. Aruna Panda, being a first speaker, and with her maybe some of the commitments back in her office. So I would like to call her first to present on her views on Alliance for Pathogen Surveillance Innovations in India. So she is currently program director for Alliance for Pathogen Surveillance Innovations, and a veterinary virologist and epidemiologist with over 24 years of experience. She holds both PhD and MPH in global health from University of Maryland, Baltimore. So Dr. Aruna, if you can hear, over to you.
Thank you very much. Good afternoon, everybody. It is really exciting to be joining this session, and which is focused on building better surveillance systems. And I would like to share my the work that we do. So I'm going to start with my slides here. I hope it is visible. Okay.
Yes, it's visible.
Thank you. So today I'm going to talk about the role of environmental surveillance in One Health. One Health, which is an approach which recognizes that the health of humans are closely related to the health of animals and the environment. And it has gained a lot of momentum in recent years because of a lot of factors which have changed the animal-human interaction, including increase in human populations, which makes them in close contact to animals, as well as the use of intense farming and deforestation, all factors which contribute to increase in zoonotic diseases. So how environmental surveillance can be a powerful tool in predicting zoonotic infections, which even have the potential of being pandemic agents, is what I'm going to discuss, giving case study or examples of what the Alliance for Pathogen Surveillance Innovations, or APSI India, has contributed. So a little bit about APSI. Using that as a model system, I can give you examples of how environmental surveillance can be a powerful tool to predict diseases. This was a consortium, multi-city consortium, which was formed in 2021 when the Center for Cellular Molecular Biology, where I'm currently working in, received generous support from the Rockefeller Foundation during the second wave of COVID. The project was solely aimed towards upscaling SARS-CoV-2 genomic surveillance in India and supporting the efforts of institutions such as INSAGOG. During that time, everybody was interested in what are the variants circulating so as to take preventative measures. So this has been a 4-year project now, and we have developed partnerships with institutions all across the country. The phase 1 of this project was solely to form an advanced surveillance platform incorporating genome sequencing using enhanced bioinformatic and data analytic tools to create a database of SARS-CoV-2 genome sequences and basically form standard pipelines, which we can share across our partners in the end with an aim to create sustainable surveillance model. This gives you a picture of the extent of our collaborations across the country. We have sites in Hyderabad, Bangalore, Delhi, and Pune. The institutions in red are the ones heading each cluster or city. They have several partnerships with institutions in their regions. So this really helped us to create a robust network of institutions, all focused towards finding out the nature of the variants circulating during that period. During phase 1 of this project, we could sequence as many as 48,000 clinical samples. Sequences of these were submitted to INSAGOG, as well as GSAID, which is a global platform, the largest database in the world, which has the repository of influenza as well as SARS-CoV-2 variants. This helped us to promote both the national and global data sharing during that critical period of the pandemic. We went in phase 2, whatever we learned through SARS-CoV-2 surveillance of clinical samples, we wanted to expand it to environmental sampling because the virus could be seen in wastewater. So we basically set up standard pipelines and procedures to detect pathogens beyond SARS-CoV-2, which included pathogens of zoonotic potential, such as the influenza viruses. These include the highly pathogenic avian influenza, HPAI, H5N1 strains, dengue viruses, and bacterial pathogens, which included those who contribute to antimicrobial resistance, AMR, which is such a big global health threat nowadays. So the idea, again, of this program was to create sustainable surveillance models, which could be utilized in the end by public health authorities. Basically, the systems which we have developed through this program, we intend to hand it over to public health systems in India who can further use it and complement environmental surveillance to the currently existing clinical surveillance programs. The idea is to prevent zoonotic diseases, reduce antimicrobial resistant infections, and basically improve human and animal health. So wastewater surveillance has been historically used as early as the poliovirus pandemic, or I guess epidemic, which we had in many years ago, where pathogens which are excreted in fecal samples of infected patients can be detected in wastewater. Wastewater surveillance has several advantages over clinical surveillance, in the sense that it can, a sample from a sewage treatment plant can give you a comprehensive disease burden assessment of a large population of people residing near those sewage treatment plants. It is extremely cost effective. It is non-invasive. It is cheaper compared to testing individual patients. And really, it can be used as an early predictor of outbreaks. In a couple of slides, which I'm going to show you next, we've seen the pathogens as early as 7 days before patients could produce clinical symptoms. So it's an early predictor of diseases, and it can be used very effectively to identify emerging and re-emerging pathogens, which can cause a huge public health threat. So this is just a snapshot of the nature of how many wastewater sites which we have created over a 4-year period across the country. We could create as many as 150 wastewater sites across 11 cities in India. We even have a site in the northeast part in Shillong, which gives you a very good data of what's going on in that region. We collected more than 15,000 wastewater samples, and these were used to assess not only SARS-CoV-2, but other pathogens of public health concern. This slide shows the clinical relevance, the correlation of clinical cases of SARS-CoV-2 and the viral load found in the clinical samples in red, and the viral load in wastewater samples in blue. You can see a tight correlation. This data is from December 2021 onwards. Basically, when during March of 2023, when clinical testing had pretty much reduced, we still saw very high viral loads. This is the Omicron variant in wastewater samples, which we were continuously sampling across the period. So this shows you that wastewater surveillance is effective in detecting pathogens when clinical testing has stopped, and also silent waves of the virus. And through whole genome sequencing, we could basically identify different variants during this 3 to 4 year period, which we have been sampling the virus in wastewater sites. And again, we could detect the Omicron JN1 variants when clinical sampling had stopped or testing had stopped. Beyond SARS-CoV-2, we also looked into many AMR pathogens. These were selected based on the Indian priority pathogen list, which also has common pathogens of the WHO list. This can be critical, high, and medium priority pathogens. And this picture shows some results from wastewater collected from open drains in Hyderabad. Through our bioinformatics and genomic tools, we could basically identify critical priority pathogens such as E. coli and Pseudomonas aeruginosa, which were most prevalent. And these were resistant to multiple drug classes. These studies could also find out which are the antibiotic classes which these bacteria were resistant, as well as the mechanisms of how they attained resistance. So a very important component of this program was to develop indigenous environmental surveillance kits. The idea is to have a very simple methodology which can detect pathogens in wastewater in a quantitative manner. And we have developed through our relationship with several manufacturing industry partners such kits which can simultaneously detect SARS-CoV-2 influenza viruses as well as respiratory syncytial viruses in wastewater. These kits have been validated across all the different cities where we have our partners in India, and they work very nicely in detecting these agents in wastewater samples. And these kits can really be repurposed to any emerging pathogens, which include, an example was when there was an uptick of mpox or human metapneumovirus cases in India, we could repurpose these kits to detect these pathogens in wastewater. And we also have kits for mosquito for vector-borne surveillance to detect arboviruses such as dengue, chikungunya, and Zika viruses, which pose again public health threats. So another thing which very important, we have developed our standard operating procedures or SOPs, which can be used by public health authorities. These are very simple SOPs developed by APSI researchers, which outline how to detect pathogens in wastewater end to end, from detection to analysis. So we submitted these SOPs to NCDC, which oversees disease surveillance in India, and we are very excited to report that their experts and APSI researchers are currently working on the national guidelines document to detect pathogens through environmental surveillance. So this will be of very great use to public health systems of surveillance in India. And these can be easily accessible at our website. We have this simple SOPs for pathogen detection, as well as the more advanced one where genomic surveillance are outlined, and they are freely accessible at our website here. Another important part of this program was capacity building. Like I had mentioned, we would like to hand over these protocols to public health authorities. So we continuously at all our centers have several workshops which provide hands-on training for wastewater collection, storage, processing, and all the pipelines which basically can be used to interpret data and report it to public health authorities. And we've had very good participation from all types of people from ranging from public health laboratories to research institutions who have attended these workshops. We are also working with NCDC. They have an epidemic intelligence services unit, which trains people in working on outbreaks. So we are conducting additional workshops with them. Through various key stakeholder meetings, we have managed to reach health professionals at national, state, and local levels in India, where we are continuously engaging with them to talk about environmental surveillance and how it can be adopted by these agencies in India for developing a sustainable disease surveillance program beyond APSI. So the ultimate goal is to basically develop sustainable disease surveillance programs and strengthen our existing clinical surveillance programs. But of course, through early outbreaks, it definitely would reduce healthcare costs and disease burden and prepare us for against emerging diseases with pandemic potential. We also are working in other environmental surveillance programs, which specifically target pathogens such as the H5N1, where we collect wastewater samples from runoff from poultry farms, dairy farms, and lakes which have migratory birds in flux. So we are also working on those which are very relevant to One Health. So just wanted to give you an, like a very quick brief overview of what we are currently doing. And we have a very well-established network in India, and we would be very happy to collaborate with interested parties. Thank you very much. I'll be happy to take any questions.
Yeah, maybe Dr. Panda, I have one question for you. Like, thanks, first of all, thanks for presenting the advanced surveillance platform, and this is much needed, which has been tested in maybe 3 cities in India currently, as you have presented. And we are really looking forward for the indigenous environmental surveillance kits as well. But as a public health professional, one question straight away comes in my mind is like, when this particular initiative or this newer technologies of surveillance are going to get integrated with the mainstream of surveillance that, as you, I guess, already in touch with that NCDC or the IHIP platform. So when can we expect, or what are the challenges maybe which you are facing in maybe collaborating these two, public health surveillance as well as the environmental surveillance as a newer or advanced method?
Yeah, that's a good question, and thank you for asking that, because having controlled and experiments in the lab is different, and then actually, trying to integrate it with public health systems is a totally different story. And this is a very much public health research initiative. So not really like the research, what scientists basically do research and publish papers and move on. So this has been very challenging, but we have been very, very lucky that all the authorities that we have met with, we've had several presentations, discussions with them, and talked how cost effective this method can be and reduce the disease healthcare associated costs in India. So they have been receptive, and one of our successes was to work jointly with them to to develop the national guidelines, environmental surveillance, document, which was it was encouraging for us that this has come a long way. And so we are very hopeful. We basically work at national, state, and local levels. We do work with municipal corporations in Bangalore, Pune, Hyderabad, and also Delhi, and trying to sensitize them, because this, even though it's a very old concept, it's still fairly, in its nascent stages. So it is very important to work at local levels and always be in touch with them. And that's what we do at each of our local areas. And we have also, of course, the Director General of Health Services, DGHS, the Health Ministry, who govern all these things. We are always reaching out to them, and we've set up, several meetings to follow up. So we hope that the relevance of this is seen in in reducing and being prepared for pandemics, because SARS-CoV-2 has taught us a lot. And that's why it picked up all these surveillance programs, after the pandemic. So we are hopeful. It is challenging, but we are hopeful we'll move this forward.
Surely looking forward to it, Dr. Panda. So maybe this is the response that I would like to invite now Dr. Oscar Primedi, who is coming from that side of the table, maybe the policy maker and the former Secretary General with Ministry of Health, Republic of Indonesia. And Dr. Oscar is a health policy analyst over last 20 years and has a experience of planning, implementing, and evaluating various health policies at both national and regional levels. So I would like to hand it over to Dr. Oscar for throwing some light on how the Indonesia has developed, or what challenges Indonesia has faced while developing the National Action Plan for Health Security of Indonesia, and what are the challenges Indonesia now facing for implementing that particular action plan. So I guess this will be more useful for us to learn both the aspects before and after, like what are the challenges for preparing the policy and after preparing the policy. So over to you, Dr. Oscar.
Thank you, Doctor. So good afternoon, ladies and gentlemen. I am Oscar Primadi from Ministry of Health, Republic of Indonesia. So I'm deeply honored to present to you today on a matter paramount importance and urgent, the way forward for building better surveillance alert response system. Talking about how the Indonesian role for the national health security. So Indonesia aligns with the global health security agenda and also international health regulation to enhance preparedness for health emergencies, and the government has taken significant steps in improving surveillance, laboratory capacity, and also the emergency response systems. So I try to, the next slide, to open about the world on the ongoing and increasing threat of emerging and re-emerging infectious diseases worldwide. As we can see, over the past decades, numerous infectious diseases have surfaced, many of which have had epidemic and pandemic potential. Detecting outbreaks early and responding quickly is crucial to preventing pandemics. Surveillance helps track emerging threats, so identify the disease that spread from animals to humans and in the zoonotic diseases and take timely action. Many infectious diseases like Ebola, HIV, SARS, MERS, and COVID-19 have shown the importance strong of the surveillance systems since 70 and until 80% of new diseases come from animals. So a One Health approach linking human, animal, and environment health is essential. So strengthening global surveillance and collaboration across sectors will help protect public health. So while emerging infectious diseases are a global threat, Indonesia faces unique challenges due to its large geographic, diverse population, and complex health infrastructure. So Indonesia is a vast and a diverse country with 272 million people. So spread across in 38 provinces and 515 districts. The scale presents significant challenges in the healthcare access gap, in governance, and also diseases surveillance. The country has over 10,000 primary health centers, nearly 3,000 hospitals, and also 1,000 private clinics and doctors. However, many population, especially 8.5 million in hard-to-reach and migratory communities, remain vulnerable, need to strengthen capacity of laboratories. Decentralization means competing rates at the local levels, leading to fragmented health data and underreporting. Given Indonesia's complexity, a robust disease surveillance system is essential to detect and respond health threats effectively. The stronger collaboration, digital integration, and also real-time reporting will be crucial in overcoming these challenges. So in this situation, our government, Indonesia, with in the condition with Indonesia's size and diverse health challenges, a robust and adaptive health system is crucial. The Ministry of Health has recognized this need, is committed to comprehensive health system transformation to strengthen surveillance and response mechanism. As you see in this slide, the Ministry of Health is committed to transforming Indonesia's health system to be more resilient, equitable, and responsive to health crisis. So this transformation is structured around six main pillars, integrating primary care, secondary care, and resilient and financing talent and technology. Regarding the surveillance, and it is in the third health system resilience transformation. This is including improving surveillance and laboratory systems to enhance emergency response, crisis preparedness, and pandemic control. This is include also better immunization, diseases screening, and stronger healthcare facilities. The pharmaceutical and medical devices sector is also being strengthened by increasing domestic production of vaccines and essential medicines. Emergency preparedness efforts including maintaining medical reserves and conducting crisis response simulations. This is part of our transformation, health transformation. And the next slide, you can see a key pillar of this transformation is ensuring effective diseases surveillance. Now, let's explore the mechanism Indonesia has put a place to monitor and respond to outbreak-prone diseases. A strong surveillance system is essential for early detection, rapid response, and outbreak prevention. Indonesia has developed a comprehensive integrated surveillance system combining indicator-based surveillances or IBS on the left side, and also ABS, event-based surveillance. More than 15,000 reporting units, including health center, from hospitals, from laboratories, and points of entry across 38 provinces contribute to real-time diseases monitoring. The system is web-based, linked to short message, and also in WhatsApp, in texting WhatsApp notification, and powered by AI tools like EIOS and Blue Dot for faster epidemic intelligence. So if you see, the key features include real-time notification and weekly reporting, and also risk assessment and rapid response within 24 hours, and 24 mandatory notifiable diseases, and hybrid to improve the health workers, hybrid training capacity building for surveillance officers. Next slide, please. While surveillance mechanism are in place, continuously strengthening capacity is essential to keep up with evolving threats. Let's look at Indonesian efforts in expanding workforce capabilities, enhancing digital surveillance, and also restructuring public health laboratories. Yeah, I can see how we can strengthening staff capacity through training and skill development, how we are restructuring public health laboratories to improve diagnostic and outbreak detection, and also digital transformation through the Satu Sehat platform, ensuring integrated health data and real-time reporting. Implementing the CISA. The CISA is an application cross minister. It is in one health concept, enhancing collaboration between human, animal, and also environmental health. So another side is how we are centralizing surveillance data at the National Data Center, ensuring accessibility and also reliability for decision making. These improvements are critical for early diseases detection, rapid response, and also pandemic preparedness, positioning Indonesia for a more resilient public health system. Next slide. This is about one major step in improving surveillance capacity is strengthening laboratory networks. Yeah, a strong laboratory network is essential for early diseases detection, outbreak response, and also pandemic preparedness to enhance laboratory capacity. Indonesia has restructured its public health laboratory system into a 5-tier hierarchies. Tier 1 is for 1,108,000 lives in Puskesmas for primary health services. Tier 2 is 329 districts level supporting for local diagnostic, and Tier 3 for 30 provincial public health laboratories ensuring advanced testing capacity. Tier 4 is 11 regional public health laboratories acting as referral centers, and Tier 5 the national laboratories for clinical specimens and also specialized testing. This restructuring align with the presidential instruction number 4 and also health law and omnibus law number 17/2023. Yes, it also supports by zoonotic disease control and surveillance. Next slide, please. Yeah, this this slide. I want to describe about the Satu Sehat. This is a Indonesian integrated digital health platform designed to connect and empower the entire health system ecosystem, including health facilities, government, and also society. This platform standardized health data, ensuring seamless integration across 10,000 puskesmas, 3,000 hospital, 18,000 clinics, and also 28,000 private practitioners in one platform. It enables for electronic medical records, access for health facilities, and Satu Sehat Mobile, allowing individuals to track personal health records in integrated wearable facilities. Satu Sehat data assisting the government in making evidence-based health policies, backed by legal framework on data protection in digital transformation. Satu Sehat ensure data security, interoperability, and also better healthcare services for all Indonesians. Next slide, please. This is I told you before about how we are collaborate among the ministry beyond laboratory, strengthening interoperability between human, animal, and also environmental health system. It is critical in detecting zoonotic diseases earlier. Indonesia is advancing this through the CISA application under the One Health approach. Effective diseases surveillance requires seamless data sharing across human, animal, welfare sectors. As you see before in the slide, reporting unit from the human, from the animal, then from the environmental also, and then go through the another system and integrate it in the CISA platform. Yeah. Puskesmas, SKDR, this is from the Ministry of Health. Animal Health Center is Hinas, and also in Ministry of Environment and Environmental Control Agency is Sehat Satellite. The system automatically verifies alerts across all sectors, and collaborative response is coordinated between human and animal health authorities. Next slide, please. While Indonesia has made significant progress, disease surveillance is a global challenge. Strengthening regional and international collaboration is crucial to ensure early detection and coordinated response to public health emergency. The COVID-19 pandemic has demonstrated the urgent need for global cooperation to detect and respond to outbreaks effectively. To build a more resilient global health system, we must strengthen cross-border collaboration and surveillance networks. Yes, you can see how pandemic funds and G20 initiative to enhance global preparedness and cross-border collaboration such as ASEAN, Biodiaspora, GORN, and HPID to improve outbreak intelligence, AI and big data for real-time outbreak detection and early warning system, strengthening laboratory workforce capacity in low and middle-income countries, expanding genomics surveillance through from site and also pathogen genomics initiative to track emergencies variants, adopting the One Health approach to address the interconnectedness of human, animal, and also environmental health. This is HPID background, this is HPID structure around 3 key pillars led by the different ASEAN countries. Vietnam for prevention and preparedness, focusing on proactive disease prevention strategies. Indonesia, detection and risk assessment, strengthening laboratory networks and field epidemiology for early outbreak detection. And also Thailand, response and risk communication, ensuring rapid and effective public health response. These pillars are supported by information sharing, capability building, and research innovation, making HPID a regional center of excellence and resources hub for health emergencies. By working together, I believe ASEAN can enhance resilience against pandemics and emerging infectious disease, ensuring better health security for our member states. So the recommendation, this is to ensure surveillance systems are effective. And this is how to enhancing cross-border collaboration, establishing real-time data sharing and interoperability between countries, strengthening regional networks such as Asian Biodiaspora, GON, and HPAID, yeah, and also investing in digital surveillance and AI-driven tools, and also providing institutionalizing the One Health approach, and strengthening surveillance requires a coordinated, technology-driven, globally integrated approach, investing cross-sectoral collaboration, digital transformation, capacity building, and One Health strategies. We can enhance global preparedness and respond to emerging health threats. So this is our conclusion about the next pandemic is inevitable, but our level of preparedness is choice. What has witnesses and devastating impact of emerging infectious disease, and it is clear that strengthening national and global surveillance system is no longer optional. It is critical. Yes, thank you. This is my presentation. Thank you very much.
Thank you so much, Dr. Oscar. I think that was very enlightening talk about the Indonesia surveillance system, and I think there is a lot to learn from the Indonesian surveillance systems as well, because I can see there are quite a few digital interventions which are already being implemented by Indonesia. And I think that has forced me to change the sequence a little bit. And now I'd like to request Dr. Sneha Nikam, who is going to share. Dr. Oscar, for questions, we will come back to you. Maybe there might be more questions from audience as well. But due to time constraint, we'd like to move to the next speaker now. And you can stay back for any sets of question at the end of the session. So I'd like to request Dr. Sneha Nikam now, who is a National Program Lead for MNCH and Clinical AI Solutions with Wadhwani AI. And Dr. Sneha comes with expertise in health informatics and AI technology, as well as she is a passionate public health professional and has over a decade of experience of working with various governments, state government, national governments, as well as CSR initiatives and public health organizations. So I would like to request Dr. Sneha to kindly elaborate more on how AI solutions can help us in strengthening surveillance systems, and are there any case studies from Wadhwani AI which are currently being implemented for strengthening the surveillance systems? Over to you, Dr. Sneha. Yeah, please. Yeah, you can maybe.
Okay, lovely. So firstly, good afternoon, everyone. I hope I'm audible till the last seat, because I'm not going to allow you to have a nap during this session. Okay, lovely. So firstly, good afternoon, everyone. And I'd like to thank the organizers for inviting our organization, Wadhwani AI, to this wonderful conclave with so many stalwarts sharing all their critical insights onto this very critical topic of surveillance. So on that note, in the next few minutes in the session, I'd like to take you through what are the different modalities through which AI could be leveraged in order to strengthen the surveillance system. Can I request the presentation, please? Or maybe I'll just take the mic and roam around. I think that will be more comfortable. Yeah. So next slide, please. So quick introduction about our organization. Wadhwani AI is a not-for-profit organization, and we are working closely with the ministries for developing and deploying AI solutions. How are we doing it? Next slide, please. We collaborate with the ministries for identifying the problem statement where AI solution could actually be complementary to the existing programs and the capacity building efforts which are being initiated by the ministry's various projects. So these are a couple of ministries with which we have already collaborated. Next slide. So as on date, these are the three domains in which we are working, mainly healthcare, agriculture, and education. Next slide, please. Okay, so in the next few minutes, we'll be focusing on the A, B, C, D, where A being how to leverage AI, B being what are the benefits of AI, C being what are the challenges with respect to AI, and last but not the least, we'll discuss about what are the do's or the way forward if you want to leverage AI technology. So before we deep dive into how to leverage AI, would anybody like to volunteer and help me understand what according to you is AI? Feel free to use any native language you want to. I mean, it's okay. What does AI mean? You can speak from your seat. Okay, lovely. Artificial intelligence. What does it mean? What does AI mean? What does artificial intelligence mean? What strikes you when we talk about AI? Okay. Oh, lovely. This is what ChatGPT has done to us because that's the first example that pops our mind and nevertheless true. So, yeah. Any other example? Okay. Yeah. A technology that reduces the human efforts. Perfectly fine. So next slide, please. So just to, as a public health professional, it is very critical for us to first unfold the mystery behind the word AI, because the moment somebody talks about AI, we feel, oh, I don't know about this. Oh, this is some advanced technology. Oh, maybe I will not be getting into the details of it because I do not have the technical details of it. And that's exactly what we will try to demystify today and understand what exactly this AI technology is and how could it be leveraged in the sector of surveillance. Okay? So what is artificial intelligence? Basically, it is a branch of computer science which enables machines to perform certain type of task. What are these tasks? Tasks which we as humans find it a little intensive to conduct or requires a lot of efforts in terms of human resources, be it time, energy, resources, whatever, or to discover certain patterns that we as humans may not be able to identify. Understood? Are we on the same page? So basically, it's a branch of computer science where you are enabling the machines to perform certain tasks to make your life easy, right? Now, having said that, how do we enable this particular efficiency in the machines? What are the building blocks of artificial intelligence? How is AI developed? What is put into the machine of AI to get the AI model? Data, big data, multimodals. So the building blocks of artificial intelligence is nothing but data. And that's exactly why we all are here today. In the previous discussions also, the delegates have time and again emphasized on the One Health concept. And for surveillance also, if we have to utilize AI, the critical concept lies behind the fact that we have to have a good hold on the data that we are generating through various platforms. Now let's try to look at what are the different formats in which this data is available as on date so that we'll be able to understand how we can use those different formats for leveraging the strengthening of our surveillance systems. Next slide, please. Okay, so these are the different modalities in which data is available as on date. It is available in the form of text, right? Any example quickly that pops up your mind? Yeah, so but that would be the model, ma'am. So any simple data जो text format में available है, OPD notes, IPD notes, right? The patient information is stored on the papers in the form of textual data. So that is one of the database that you have. Second, images, easy one. Quick answers, please. Radiological data, clinically it is being used at a large scale. Then photo of any particular critical information piece that you capture. Then the slides, the slides, the data, the images of the slides, the microbial slides in the laboratories, right? So these are the different sources. Then audio. Any quick example of audio usage in healthcare? Yes, yes. Respiratory sounds, cardiovascular sounds, they are being utilized like they are very critical information. Tabular data. Tabular data is nothing but the different kinds of databases that we already are trying to collate, which is maybe the Unmol platform, the HMIS platform, the IDSP platform. So basically a platform wherein you are populating all the information from different sectors and trying to put it together. So these are the different formats in which data is available as on date. Why is it important to understand these formats? We'll go to the next slide and try to understand. Next slide, please. Okay, so each of these different formats can be utilized for developing different kinds of AI models, right? So I'll quickly run through the names and we'll go through detail a little later. So first is predictive analytics. The word itself helps you understand it. It is able to give you certain kind of predictions, right? Second is geospatial analysis. Third, audio speech recognition. Some of my colleagues already mentioned it. Image-based screenings, as you rightly mentioned. Generative AI and LLMs. This is the most widely known and I would say celebrated AI tool across the globe right now because of ChatGPT and media surveillance, right? So we'll go in detail a little bit for each of these different modalities. Next slide, please. First, let's try to understand what is predictive analytics. Anybody wants to volunteer quickly? Okay, so in the interest of time, I'll take it ahead. So predictive analytics is what? You are analyzing a certain set of data information that you already have, and you're trying to come up with a certain predictive output from it. Why is this prediction critical? Because it helps us in risk assessment. It helps us in identifying which are the individuals who are at more risk for a particular label. Now, when we are saying that, there are certain things that we should keep in mind for predictive analytics. The database that you utilize for developing such kind of predictive models should have the input and the output labels. So what does input and output labels mean? Right. So basically, what are the set of parameters that would influence a particular outcome that you're looking for? For example, you're looking for, say, dengue outbreak. What are the indicators that are going to have an impact on the outbreak? So a line listing or a data set which has end-to-end information regarding the input and the output will be essential for you to develop an AI model which will be able to provide you predictive analytics. Let's quickly have a look at a few AI tools that we have developed in this category. Next slide, please. Okay, so this is one of the AI tools we have developed in the maternal and the child health section. So we are working with the state government of Madhya Pradesh, wherein we are using the data set from Anmol. Anmol is basically A&M Online, where the auxiliary nurse midwife fills in most of her RCH data and tracks in the pregnant woman's life cycle, right? So in a nutshell, that's what it is. So what we are doing is we're utilizing the data captured during the registration of the pregnant woman in order for the frontline worker, which is the A&M in this case, to understand what is the likelihood of that pregnant woman completing all the 4 antenatal care visits, right? I'll repeat. It is helping the frontline workers identify which are the pregnant women who are most likely to not adhere to the 4 antenatal care visits which a pregnant woman is supposed to complete during her pregnancy phase. How is this important? It is kind of a risk assessment scoring which will help her intensify her follow-up visits. That is one example. Second is we are also working for development of an AI tool which will utilize the data points captured during the ANC period for predicting certain clinical morbidities the mother and the child can have during the postnatal period, like pregnancy-induced hypertension, preeclampsia, eclampsia, stillbirth, live birth. All of these could be predicted on the basis of certain line items that you capture during the antenatal care period. Next slide, please. And the third example is regarding PATO, which is basically a risk assessment for TB treatment. So similar to what I mentioned regarding the ANC adherence, we are working with the Central TB Division, Ministry of Health and Family Welfare, where we are utilizing the Nikshay data. So Nikshay is a portal where your TB data gets captured, right? So we are utilizing the patient registration details captured during the when the patient is already identified. So it helps the NTP staff understand what is the likelihood of the patient completing the entire TB treatment. We know the adverse outcomes of not completing the TB treatment. So this particular scoring helps the NTP staff intensify the efforts towards ensuring that the patient is completing the entire TB treatment, right? So that's in a nutshell what the AI tool is. Let's move on to the next modality. So that was it about the prediction. One of the key challenges we need to understand here is you need to have the data which has inputs and outputs. And what is the benefit of it? It will help you. What is the benefit of predictive modeling? It helps in optimization of the resources that you have. It's not possible for A&M to call all the pregnant women that are, in her due list, right? In her line list. So it helps in optimization that's the key over here. So next slide. Okay, now this is an interesting topic, geospatial analysis. So this is something that as surveillance experts, we must have come across a lot of papers and a lot of situations that we have seen through, right? I'll quickly take you through how we are using it in the current context. Next slide, please. So mainly geospatial mapping can be used for vulnerability mapping or identifying the high risk areas. And this is very critical, more so during the outbreaks. So there's a small, there's a small initiative we have taken up with the Central TB Division, wherein we are using the geospatial data. Can you go to the next slide, please? We are using the geospatial data, which is obtained from three sources, mainly three sources. One is the open source data, which is available regarding the mapping of various water bodies and whatever infrastructure is there, the crowding in a particular area, I mean, how crowded is the population, and XYZ parameters, which is basically on the socio-demographic aspect. Then the Nixshare data, which talks about the lat and the long details of the patients, which helps us identify where are the pockets where the TB patients are mostly located. And the third part is we have also tried to utilize the NFHS data. So these 3-4 data sets have been utilized in the backend to develop an AI model, which is actually able to identify the pockets where people are at more risk of having tuberculosis. So this AI tool is then provided to the NTP staff, and happy to share with you that this is already being deployed in a couple of states. So here what we are trying to do is, again, helping the state kind of intensify its activities in a particular geography, and that is nothing but resource optimization, right? Okay, so next slide, please. So geospatial data analysis was one thing. Second part that we are doing with IDSP is the media disease surveillance, which my colleague Dr. Shrikant mentioned during the start of the event. So what we have done is we have developed an AI tool, which is basically a web crawler. What it does is, we know that whenever there is an outbreak or whenever there is a event reported in a particular geography, that easily comes up into the media, right? So the web crawler, basically what does it do? It scrolls through the various media articles across the country for all the different kinds of languages that are available on the media, and certain keywords have been identified by IDSP. Those keywords, the articles with those keywords are then identified. They are then segregated and then provided to the IDSP division so that they are timely alerted regarding the kind of outbreaks in a particular geography. So this is something that we have already done with IDSP, and it's already integrated in the IHIP platform. And happy to share with you those numbers, which talks more about how the data and the AI tool is being utilized. So that's another example. Can we go to the next slide, please? Okay, so so these were the up till now we spoke about how AI could be directly used to complement the existing programmatic efforts that we are aligning towards surveillance systems. In the next few minutes, we are also going to try and understand how the different modalities of AI could also be leveraged for a few of the screening activities that could be, initiated for identifying a set of diseases. So automated speech recognition, this is being widely used. So any examples of automated speech recognition? It is very widely used. Siri, yes. Gemini Siri के बिना तो काम नहीं चलता है आजकल, है ना? So that's an example of how we are using speech. But in the context of clinical screening, can you go to the next slide, please? I'm happy to share with you that we have come up with an AI tool which utilizes the cough sounds of an individual in order to screen the individual for pulmonary TB. So this AI tool again is developed with Central TB Division, and we are using it in the ACF, that is active case finding activities done through NTP. And it is not being used as a standalone application as yet. We are using it along with the clinical rules algorithm that the Ministry or the NTP has already put in place. So 4-5 symptoms Ministry has already identified that these should be screened for during the active case finding. Apart from that, cough sounds are also being captured and the individuals are being screened in order to understand if there is a probability of the individual having pulmonary TB. So that's how cough sounds can also be, sound voice or the patterns in your voice could also be used to screen any individual. Especially this is critical when we are talking about mass screenings, right? Because laboratory tests are easily available, right? It does not require much resources. I can see a couple of slides, smiles that helps me understand that a few individuals are awake. Okay, so why are we doing this is again, the same thing, resource optimization. So time and again, I think one of the key messages that is coming up from all the AI solutions is that we are trying to complement the existing surveillance systems mainly for the purposes of resource optimization by providing them timely alerts, right? Next slide, please. OCR is also one of the techniques which is being widely used as on date. We have used it for a couple of reasons, like we had an interesting use case where there was a demand from from Uttarakhand for preserving the Tibetan culture, right? So we tried to develop a technology for them, which kind of translated the Tibetan language into a readable format. So this was used mainly for the text as well as for the video recordings that they had. So this kind of technology can be used in healthcare as well, because as on date, we have a lot of data being captured on the hard copies, not really available in the digital platform. That could be translated into a digital platform. So this is something, but of course, this is a cost intensive thing. So I would not really recommend it for a public health system. But again, this is a modality which we should be aware of. Next slide, please. Next. Computer vision, image-based solutions, like we spoke about the clinical images, right? Next slide. So diabetic retinopathy is again one of the conditions which is not very widely screened for in all the people who have been diagnosed as diabetics. So this is the AI solution that we have developed in collaboration with AIMS Delhi, and happy to share with you that the tool can be integrated in any platform that the ophthalmologists are using. And this does not really require an ophthalmologic, a basic image captured on a smartphone, which is again connected to the right fundus device, helps to identify whether the person is susceptible or there is a probability of he having diabetic retinopathy. So such kind of solutions can be used at a mass scale for screening populations for a particular outcome that you guys are looking for. Next slide. Having said that, I think in the next few slides, next slide. Generative AI LLM, how can it be used for surveillance purposes? Can it? Not necessarily directly, but in an indirect way, where you have the response systems being supported by something like a chatbot, wherein you're able to identify what are the kind of queries that are coming up by the health teams or whosoever is the response team, so that you understand where is it that capacity building needs to be intensified. Is there a particular topic which needs to be addressed well? Is there a particular topic for which you need to develop audio visuals or kind of some kind of digital modules to help them understand the concept better? So that's how actually chatbots or LLMs could actually be utilized. So it's way beyond the actual chat GPT usage that we are doing as on date, identifying the queries and intensifying the capacity building efforts in that direction. Next slide. Quickly, in the last 1 or 2 minutes, let's talk about what are the challenges with respect to AI. All good factors we've already seen about, acha, AI aa jayega, to ye hoga, wo hoga. But having said that, it's very important for us as public health professionals to identify a few key areas where we should be very sensitive with respect to the usage of AI. A few of them I've highlighted on the slide, but a few of them I would like to really talk about is about building the infrastructure. Is it so that our health systems are really strengthened enough to actually accommodate these AI tools? Do they have the required information regarding the development of the AI tool? Is there enough transparency regarding the kind of the training data that has been gone into the AI tool development? Do we know the pros and the cons of the AI tool development? I think asking these questions is very important for us as public health professionals to take a decision on whether an AI tool could be a savior for us in a particular situation. So, and the next slide, please. So what is it that we can do in order to ensure that we have good AI systems in place? I think one of the key aspects is collaborations, a collaboration between AI development organization, academic institutions, and the state stakeholders, so that there is an ecosystem which has a bird's eye view on the kind of AI tool which is being developed, adopted, and deployed, right? Secondly, ensuring conducive atmosphere in terms of capacity building of our stakeholders, capacity building of the IT professionals at the state level. IT department ही है जिसको आगे जाके they have to actually adopt it, ensure the uninterrupted usage of it. So ensuring a conducive atmosphere, the data governance and standardization, I think that we have very well spoken about in the last few sessions, and ethical AI development and deployment. So ensuring that whatever programmatic interventions you design around the AI tool inference, they are ethical and they are not biased towards a few individuals owing to the training data set leading to the AI inference going in that direction. I think these are the critical indicators that we all should keep in mind. And on that note, maybe I'll just close the session. Thank you, everyone.
Thank you, Dr. Sneha, for demystifying the concept of AI, giving so many case examples of how AI is being currently utilized through Advani AI, and of course, waking up the audience. So I would like to quickly hand it over to Dr. Chang Li. He is a senior epidemiologist at Epidemic Intelligence Center, Taiwan CDC, Ministry of Health, Health and Welfare, Taiwan, and request him to quickly maybe give his view on how CDC is collaborating and helping out Taiwan for strengthening its surveillance system. And if you want to point out on any of the plans being made on strengthening the surveillance systems with Taiwan government. And I would also like to request Dr. Chang to kindly keep it short, maybe 10 minutes. I know I have promised you 15 minutes, but we are running short of time. So over to you, Dr. Chang. Yeah.
Okay. Good afternoon, ladies and gentlemen. Can you hear me?
Yes, we can hear you. Please go ahead.
Should I share my screen, or you can
Yes, please share. Please share.
Okay. Okay. Can you see my slide?
Please go ahead.
Okay. Hi everyone. My name is Chen Li. I'm from Taiwan CDC. It was a great honor to be invited to discuss how Taiwan complete the surveillance system for disease X, lessons learned from COVID-19, and the use of AI to detect potential public health threats. I joined the Taiwan CDC in 2002 when I was young. This is my 23rd year in field infectious disease control and surveillance, and I'm now the chief epidemiologist and also the associate researcher in Taiwan CDC, Ministry of Health and Welfare in Taiwan. My primary duties are disease surveillance and risk evaluation for local and international threats. I'm also the chief consultant for the Minister of Health and Welfare when combating COVID-19. As you might know that Taiwan adopted a zero COVID policy in the first 2.5 years of COVID-19, from January 2020 to April 2022. However, small outbreaks still occur in 2021 due to the Alpha and Delta variant spreading in the communities. But after public efforts, Taiwan was back to zero COVID after 4 months. Taiwan adopted the zero COVID policy because our experience with SARS in 2003. The SARS epidemic lasted around 4 months. Nearly 348 confirmed cases and 81 deaths. However, it caused 1.2 GDP loss, which cost $2 billion in 4 months. Therefore, we know that we need to be very cautious about the unknown diseases. Therefore, Taiwan construct the COVID-19 Central Epidemic Command Center, a cabinet level, gathering all high-rank officers to work in the same buildings. And Taiwan had a very strong system for the local and imported cases of the COVID-19. We also adopt a strict border control for the quarantine policies to reach the status of the zero COVID-19. The Minister of the Health and Welfare assigned me to conduct a nationwide zero prevalence study to verify whether zero COVID was real or not. We know that the anti-nucleocapsid protein would become positive if infected with the COVID-19. We know that we can see in this figure, fortunately, until April 2022, less than 0.5% of the whole population of the 23 million people ever infected with the COVID-19. And after that, And after that, we abandoned the zero COVID policies in May 2022. And you can see the amazing increase from the May and June and July. And according to the Lancet, Taiwan had one of the lowest excess deaths worldwide during the COVID-19 pandemic. And also you can see the Economist magazines also demonstrate that Taiwan was ranked 9th lowest for excess deaths globally. So developing Taiwan's epidemic surveillance and control policy in the post-COVID-19 era is very important for us. So now I want to show you how Taiwan CDC the surveillance systems for communicable diseases and public health events. We utilize the zero prevalence research to examine our surveillance systems with indicators of infection detection rate. Zero positive is this one. The zero positive is actual infection, and we compare the number with the notified number. The Taiwan CDC also utilize various indicators to test our surveillance systems. From the surveillance perspective, I would like to use the iceberg figure for demonstrations. From the surveillance systems, we can only see the tip of the iceberg because this is for the infection and symptomatic and also seeking for healthcare and notify to authorities. So that you can see those people in the surveillance system. However, under the sea, there's huge part of this iceberg you will not understand or you will not figure out how big is this in the icebergs. So we need various systems to gather information. Taiwan CDC's surveillance system include indicator-based and event-based systems, as Dr. Oscar Primidi from the Indonesia Department of Health demonstrate. We regularly receive data from the notification system, Sentinel physician, and various systems for the indicator basis. Indicator basis, we call it data. And from the other side is the event base. The event base is which gather information from the media and social network, and also the WHO and other intelligence from other countries. We use the electronic medical records to report the notifiable diseases because in Taiwan, over 99% were covered by the National Health Insurance. So we cooperate with the National Health Insurance to ask them to reimburse the hospital information system so they can utilize these APIs to upload their data to us. And also, for large numbers of notifications, we cooperate with the NHI, which cover 99% of the population. This is to solve manual entry and decrease the workload on the frontline workers. We also utilize the National Health Insurance claim data to obtain syndromic information. And this is the media watch room, and it serves daily. We gather news from the news channel and social media, including the Facebook, Weibo from China, and the Twitter, and the PTT. PTT is the bulletin board like Reddit in the United States. We also gather international intelligence from multiple sources. While there's a breaking news, the news channels will report and show it on the running screen. As you can see that from the running screen, if we have outbreaks in the community or in some other areas, it might not be easy for human eyes to catch so much information on nearly 20 channels at one time. Therefore, we use the AI. We use this technology called automatic deep learning system to capture specific keywords that appear on the news channels. The system will capture the running titles on the screen each second and analyze whether there are specific keywords like outbreaks, fever, or COVID, or other epidemic relevant news. When it matches, the system will notify the officers in charge. And concerning the international news gathering and analysis, the Taiwan CDC use the natural language and AI-assisted systems for the gathering and epidemic information. As you can see, this is the Google spreadsheet. We use the Python technology to collect designated web information and keywords from the Google News and WHO and other medias. While collecting into the system, it will categorize specific disease and areas. And this is the news source. And the title will translate to Chinese automatically. And it will use the ChatGPT to abstract the whole articles. And it will also keep the system is very helpful for us to gather the whole news sources from the world. And here's the conclusion of my slides. And challenges encountered by Taiwan CDC. For many countries with Taiwan has strong relations, such as India and Indonesia and Southeast Asia countries. We have very strong relations. However, it's very challenge for Taiwan to obtain the local intelligence of the infectious disease from your website. So I would request for further cooperation opportunities for epidemic intelligence sharing and fact-checking and at the national and federal levels, and deeper exchange with youth experts from various countries. Furthermore, Taiwan has a very strong AI power and is willing to share our experiences with global partners. Okay, that's my slides. And the QR code, you can scan the QR code to download my slides, and I'm happy to share and happy to discuss and take questions. Thank you very much.
Thank you, Dr. Cheng. I think that was very insightful, but unfortunately, we are running out of time for any questions. I know there are maybe multiple questions, but we'll surely invite you again to share the details of all the AI power what Taiwan has and what they're currently utilizing in the surveillance. So I would like to maybe request Dr. Vijay Eldandi now. He's our senior most panelist and infectious disease specialist to give his views on how to strengthen the surveillance systems and what are the components which are really he thinks are important for strengthening the surveillance system. Sir, over to you quickly.
Thank you. So firstly, please, I'm just a dumb ID doc. So I'm going to simplify and demystify surveillance for you. First of all, in the entire audience, can I see a show of hands? How many of you are in training in public health or any kind of health? Trainees? Wow, a lot of young people. So I made from my surveillance 2 observations. A lot of you young people are in training and a lot of you are interested in public health. Simple surveillance. All right. Now let me tell you a few anecdotes from my own experiences that will illustrate what we mean by surveillance. How does it help us? And most importantly, what's the connect between improving somebody's health? My first challenge when I started, when I was your age, I was young once. I was never beautiful, but I was young once. All right. So I was handed a whole bunch of lung transplant patients who had aspergillosis. And I said, wow, because I looked at all of the other immunocompromised patients, the heart transplants, the bone marrow transplants, the kidney transplants, and their incidence of aspergillosis was negligible, under 5%. And here was lung transplants that was bordering on 15%, 3 times as much. So it did a big detailed epidemiologic investigation, finally came to the conclusion that lung transplant intrinsically, in and of itself, was a risk factor for aspergillosis, and therefore everybody should be on routine prophylaxis for aspergillosis. We were the first program to start that throughout the world, and now it is part of standard of care. So surveillance, because early in my training, we were taught that we should go to the laboratory, look at any unusual pathogens or anything, and anything that looks out of the ordinary requires an investigation. Okay, so that is the definition of an epidemic. Any kind of problem that is outside the ordinary is an epidemic. All right, very simplified definition. The second part is when I first came to India and I started looking at HIV, because I thought that just like sub-Saharan Africa, India was at risk for a major catastrophe that potentially could lead to demographic collapse because of economic collapse. So one of the first things we did was institute routine HIV testing for all the voluntary blood donors at Medicity hospitals, where I and Dr. Krishna Reddy were working many decades ago. And we found that there was a little bit of background amount of HIV infection among the volunteer blood donors, which was roughly around about 1/3%. But what blew our mind was just 40 kilometers away in a suburban area, the pregnant women had 3 times as much HIV, more than 1%. I said, oh my God, HIV is not restricted to high-risk groups. It has penetrated the general population. So we were amongst the first to generate the evidence that led to the conclusion that HIV in India was no longer restricted to quote-unquote high-risk groups like truck drivers, whom we also studied. Everybody said 40 to 80% infection. We found less than 2.5% infection. All right. So that's the importance of understanding what surveillance means. Surveillance simply means open your eyes and look at what's happening. That's it. That's all you need to do. And then quantitate it. All right. And after that, hand it over to really smart people who can do AI and stuff like that. For us, dumb ID docs like me, real intelligence. Okay. Next. Coming to, trying to understand how to predict disease, because by the time we diagnosed CMV disease, which was a major risk factor for aspergillosis and lung transplants, there was a lot of morbidity and some mortality. So I said, this doesn't work. Now let me look at all of the risk factors for CMV disease. And I looked at reams and reams of serology and came to the conclusion it's worthless. Then we said, you know what? Just like HIV, we ought to do CMV viral loads in the blood. And that's what we did. So we introduced that technology, which was at that time experimental, and routinely looked at every lung transplant for the blood level of CMV virus, and also at the same time tried to correlate it with the findings on a transbronchial biopsy, which they underwent on a routine basis every week. And we showed that the blood viral load of CMV would predict the occurrence of invasive CMV disease diagnosed by lung transplant by several days to several weeks. So we put all of these high-risk people on prophylaxis using oral ganciclovir, which was the only thing that we had available there. Now today we have better agents. Next, coming back to India. And I was very interested in doing quote-unquote surveillance of various kinds of things. And in Hyderabad, we found a lot of metabolic syndrome in very young people, college-going students. We repeated that study amongst the Chenchu tribals to see if migration from their usual habitat, sylvatic, to urban would make a change. And we did see some change. But I wanted to do this on a much bigger scale. So we designed a project called HAPPEN, Health Advancement Peer Partners Empowerment Network, to go out and do a participatory research study amongst the entire Chenchu tribal population and compare it to an urban population and see what's going on. So I go to one of these meetings with all the Chenchu tribes, and here's another big lesson I learned. What? We health professionals are guilty of living in our own echo chambers. And just like George Bernard Shaw said, every profession is a conspiracy against the laity. And here I was talking to the Chenchu tribes about metabolic syndrome, diabetes, blah, 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 blah. And the women there, they listened to me. You know what they said? Our major problem is our spouses getting addicted to chewable tobacco, gutka, and alcohol. And you are talking to us about this, that, and the other, blood pressure. We don't have blood pressure. We don't have a headache. It's our spouse that's causing us a headache. So the final thing that you learn about surveillance is if you're overly medicalized, you're going to miss out a lot of things. And this is like what Friedrich von Hayek said in his 1974 Nobel Prize lecture. He said, this is the pretense of knowledge. We look for things that we know about. What about all the other things that are really, really important, but we know nothing about? So we need to develop a true surveillance system. It is my dream that we will build a surveillance system that is community-based and that will tell us not just medical problems, it's not medicalized, but would alert us to social stress. So I should be able to prevent a big ethnic conflict by using my tools. So that's surveillance. And I hope that all of you really develop your skills in public health. It is one of the most gratifying things that you will ever do. It has been in my life. So please go ahead and do it. We need your strength. We need your energy. We need your ideas to give everybody a purposeful life with autonomy and dignity. Thank you.
Thank you so much, sir. I think that was absolutely a balancing, I think I would say panel discussion where we discussed about the newer technologies with Dr. Sneha, Dr. Aruna with wastewater surveillance, Dr. Cheng emphasizing on how AI helping Taiwan, Dr. Oscar and Dr. Vijay are talking about how they have seen the surveillance system evolving and what is the traditional methods of maybe surveillance as well as demystifying the surveillance concept itself. So this is how we are going to take it forward also. I know 90 minutes are not enough and I have next session to lined up again. But we will keep on maybe organizing this sort of sessions and engage more with these speakers as well as other experts in coming days in our peer-to-peer sessions and taking the thematic area of surveillance alert and response system forward. And with this, I would like to thank all the panelists for taking out the time and coming here, joining us and sharing their insights with us. Thank you so much. And I would like to hand it over to Dr. Uma now.
Thank you, Shrikant.